Hello, everyone. More people are trickling in. We're very excited to see you in this meeting today. Thank you very much for joining. We are asking everyone if you want to rename yourself on the three ellipses in your upper right-hand corner. If you can rename include your name, the title, and your organization, that'd be appreciated. Hey, Vicky, how are you? Good to see you.
Hi, James. I'm doing good.
Nice. Good to see you. Hey, Jennifer. Good to see you as well.
Hello.
Hello.
Hey, how are you?
Very well, thank you.
Good. And how are you, DJ3? Have you always gone by the name DJ3? I mean, your whole, even growing up as a kid?
No, not at all. I was in the military for a number of years.
Yeah.
And so, first of all, let's start. My formal name is about this long. It is David Devon Lee Jackson the third. So that was a mouthful. In the military, there's a provision in the regulations that allows, if you have multiple people in an organization with the same last name, to use either a first initial or something to separate so people understand who they are. So I became Jackson the third because that was my actual name. And then as I transitioned out of the military, went to another organization, someone made a joke and said, "We're gonna just call you DJ3." After he was trying to make a Michael Jackson 5 joke and it just crashed and bombed. But DJ3 stuck, and so I've been DJ3 ever since.
That's a funny story. Hey, that's how nicknames come around, huh?
Exactly.
Someone's got to make it up for you. Well, I think DJ3 is a pretty cool name. I could be James 2 or something of that nature.
So, all right, then we'll make it so. From this day forward, we dub you James. Now, do you want to be just James 2 or do you want to be James the second?
Or who's the other James? That's what I'm not sure of.
Whoever you like.
I only know myself.
Or maybe you could be James 002.
Ooh, there you go. I like that one. 002. Okay, I could go with that one. 002. Welcome, everyone. We're really glad you can make it at this meeting. We are going to be starting in just a little bit. If you could go ahead and rename yourself in your box. If you go to the upper right-hand corner, there's 3 ellipses. If you click on those ellipses, if you can include your name, title, and organization. And one more thing, if you could make a brief introduction into the chat. We are also asking a quick response of what are you looking to do this spring? What are you going to do this spring? It seems like we're in a whole new year and world, and it's constantly changing. But we'll be starting soon. We've got a great presentation today, great discussion with industry partners and with education. Lots of good information is coming your way, and we are definitely excited for our speakers and for all of the participants. And this is definitely a rich discussion that we're going to keep engaged and informed.
Okay.
Thank you, Terry. Thank you, DJ3. Thank you, Heather. Thank you, Joanne. Angie said we're going to start having in-person career fairs. Wow. Denise is going to explore Seattle. That's right. Denise, how long have you been here now? I think you've been here a few months.
5 months.
5?
Mm-hmm.
5 months. If you need any fun sites, I've got plenty.
I'll tell you.
The 3 ellipses are in your upper right-hand corner of your box. If you hover over your box, the 3 ellipses will be right next to the mute And if you click on that, you can rename yourself and include your name, title, and organization. Kim is going to enjoy her new granddaughter. Congratulations, due May 1st. The question that we're sharing is, what are you looking forward to doing this spring? Because we are in a new spring. Thank you, Jennifer, for joining. Shireen, we're happy that you're here. Sharon, thank you. Maria, happy that you're here. Morgan, welcome. Yes, it's good to see some old friends. And it's always good to see Vicky. Vicky's in the house. Jennifer Graves. John.
And my sister Angie.
Yeah, I know. We were wondering, huh? So no real relation, or is that something you're sharing? I think you're on mute.
But we're long lost sisters. We both used to work at Kaiser, and that was kind of our thing. I miss you, Jennifer. I miss you, Joanne. I miss you, Amy. I miss you all, Kaiser people.
Well, it is
We miss you too. Your family. We are family.
It is 3:07. We are going to go ahead and begin to move this right along. Thank you and welcome everybody. We are super excited you're here. Give yourselves a round of applause for making it to a meeting on Hump Day. It is a beautiful day outside and all of you have decided to join us, and we are definitely excited that you're here. We have a great discussion today. There's lots of great information that we are helping move forward in addition to this great meeting. As you know, this is the HILT Healthcare Industry Leadership Table. This is the Education Information Exchange, Spring 2021. So welcome everyone. If you would kindly, for those that are just entering now, if you hover over your box, you can rename yourself. If you press on the 3 ellipses in the upper right-hand corner, if you would include your name, title, and your organization. The quick response in the chat box is, what are you looking forward to doing this spring? We've got some great responses so far. We have little grandkids being born. People are exploring Seattle. People are going to go for a swim. They might even have a party, a small get-together that is safe. And we really hope that this spring is a different spring for everyone. But we are definitely excited. So please do introduce yourself into the chat. That is a great way for us to know that you're here and recognize you, that you're here with us today. We're going to start out with the HILT purpose and vision, just as an overview for some folks that might be new to the meeting format. The HILT purpose and vision. HILT is a network of diverse, small and large healthcare providers who come together to share and take action on improving access to skilled healthcare workforce. The vision, since its launch in May 2018, we're coming up on 3 years, HILT organizations have made improving equity and diversity in the region's healthcare workforce a core guiding principle across its communities. And we are thankful for the HILT network. So thank you everyone for being part of this. The purpose of the quarterly meetings, and this is why we have several different kinds of meetings, but the purpose of the quarterly information exchange to be a forum for consistent and quality information sharing between our region's post-secondary education institutions who train and educate students for future healthcare careers and the healthcare organizations who hire them. So we are directly integrated into that. And I'm going to pass it over to Lindsay.
Great, thanks, James, and hi, everyone. We're going to dive right into this quarter's information exchange. The feature, which hopefully you saw in your invite and the agenda, is changes in nursing. And so that's both obviously on the skills demand side from our healthcare organizations, and particularly post-COVID, if healthcare organizations have noticed what different types of skill sets and knowledge might be needed in your nurses and nursing staff out of COVID. And then we're going to hear from our education partners. partners. So same format that we use every quarter for our education and healthcare organization information exchanges. This was an idea, just a reminder, that the captains came up with last fall when we realized, or they realized, there wasn't a consistent form of communication. So that's the topic, is nursing. And we're going to start off, as we always do, hearing from our healthcare organizations. We have a very good lineup, as you can see, for our kickoff comments. And each organization, and that includes today Healthpoint, Aegis Living, Kaiser, as well as Public Health of Seattle-King County. Each organization will have just about 5 or 6 minutes to kind of give us the upshot, and we will share the questions momentarily. Let me just run through the lineup of speakers very quickly. We will hear from DJ3 and his colleague Heather Selby from Healthpoint. So that will be our kickoff, and then we will move to Angie Graves, who will talk about nursing staffing needs from a long-term care setting, Aegis Living. Then we'll hear from Jennifer Graves, VP of Quality and Safety at Kaiser. Similar topic, of course, on nursing. And then Doreen Hirsch, who is the Chief Nursing Officer from Public Health, Seattle-King County. So thank you to all of you from healthcare organizations for committing again to sharing this information with our post-secondary education partners. And so at this point, if you can switch to the next slide, James, we'll put the questions up. And DJ3, I'm going to kick it to you to kick off for Healthpoint and bring Heather in as appropriate. Does that work?
That's wonderful. And so I'm actually going to say, Heather, take it away.
Oh, thanks,
Welcome,
DJ. Appreciate that. And hello, everybody. And there's a number of colleagues on the call today that I know personally. So big hi to everybody. Miss you all. So in terms of in family practice and primary medicine, the biggest impact we had in the system is, frankly, we can't compete with the acute care system in terms of recruitment, salaries, and retention. And so we're always short. And I think the pandemic actually escalated folks to retire early in our case, or leave nursing because it was so stressful. The biggest thing I would say in terms of changes, and I know the schools, many of them personally are working on this, but population health is a real big area that we've moved into in primary care extensively. And so really having a grasp of population health, the impact, and looking more globally as well is a big piece for Healthpoint in terms of understanding the global nature of healthcare and the diversity of the patient populations that we're serving here in the Puget Sound region. Another area, I have a little list for you, is case management at a basic level. So again, I've been a faculty and dean of nursing, so I know nursing curriculum well, and this is a bit higher level, but just the basic understanding of how to manage patients, whether they come from the ED back into the primary care setting, or primary care back to the ED, hospital, or long-term care, is an area where we could use some focus. Another area is, although we teach across the lifespan in nursing school, we don't necessarily talk about primary care, community health as much. We do some good work in public health, and I know Doreen's happy about that, but our work in community health is slightly different, and it's a niche area that is growing exponentially, and we could use some help there. Jennifer Graves will like this one. Quality measures and quality assurance is a big area as well, where we use a tremendous amount of data here at Healthpoint to address our needs and our patient population. And we're actually reimbursed federally on our quality measures and how we perform, for example, improvements on A1C results with patients, for example. Finally, I would just say infection control is another one. And again, being a former faculty and dean, pretty aware of this, but COVID really reared its head, and the need for people to really understand and nurses to lead infection control was really paramount. So those are the big things I see. What other effects and outcomes your system experienced due to COVID? Well, Certainly, I think the biggest thing was reinventing ourselves in terms of working in a virtual environment with our patients who, again, are somewhat technically challenged or don't have access. And we've really had to do a tremendous amount of work to support our patients, but it's been very successful teaching our teams how to work virtually. We use a product called Auto on interface with our EMR system has been challenging. And then I would say, we really did a 180 on how we think about access. And again, our access is unique in that, as some of you know, we work extensively with King County Public Health with refugees and immigrants. We're one of the largest organizations to serve those individuals coming into our region. And so we've had to rethink everything we do. And then I would say I've never had to do so much PPE ordering in all my life. I could tell you everything you want to know about how to be protected in COVID. And so I think that's the other thing that I love about nursing. And I hope my education colleagues can hear me. The critical thinking that comes out of nursing school is imperative, especially in times like this, where we really need that skill set. And that leadership from the nursing mindset who can navigate both from the operational side and from the clinical side. Any questions or comments? Did I do it under 5 minutes, I hope?
Heather, that was very impressive. I have to say, you are very organized. And just a few things that I'll call out. First of all, this is an exchange for sure. We want to get through some of the kickoff comments and really hear some common themes, but absolutely, please use the chat box to put in like, yeah, I hear that. I totally concur. That's a really important thing from the healthcare perspective. And then of course, our post-secondary education institutions out there who are from nursing programs and nursing schools, ask questions in chat too, because we can kind of capture them along the way. Of course, we're going to have time to discuss in breakouts and bigger group as well. But certainly I'm hearing understanding population health metrics and outcomes, how to manage patient care coordination and those points of transition that are so essential for quality care, the quality measures and metrics knowledge that nurses have to have in order to work with patients effectively, infection control, critical thinking. I think you named some incredibly important and very specific things. So that is perfect. DJ3, would you add anything from Healthpoint's perspective?
So I think what we also have to do is think about life cycle of the nursing staff as they're coming into the organization. How do we continue to upskill them? So yes, clearly Heather's team, at Healthpoint has got clinical trainers and they do the clinical learning, because you really don't want me in there teaching people how to do clinical stuff. That's really not my strong suit. But those other skills, leadership, communication, development, those sorts of things, we really have to think about how do we continue to grow our nursing staff, because a lot of time they're at the patient side. That's where we see them having that critical need. So how do we create systems that create space for them to be able to gain that additional learning? Additionally, I'm going to transition quickly to put on my HILT captain hat. And this is another reason why we absolutely need this forum. As Heather talked about, the competition. While we are competing with one another, we still have a population that we need to serve. And there are some folks that my organization can serve better than a larger or children's or some other organization. That doesn't mean those organizations are bad. It just means they've got a different population that they serve. So figuring out how do we come together to create the pipeline? How do we come together to create the depth? How do we come together to build the partnerships to help create enough? And there was a term and I forgot it. What was it? Cultivators. And what was it the guy said in our meeting yesterday? Cultivators and creators of resources. That's it. We've got to find a way to collectively become cultivators and creators of resources in this critical space if we're going to be successful into the future.
That's great, DJ3. Thank you for that. And I'm just going to make a little note here as well, because since the feature is nursing, I also think it's important for HILT, to your point, DJ3, to note that Healthier Here, which many of you also participate in, or your organizations do, also is sort of wondering, how do we actually get more tightly coordinated around the nursing pipeline? And I think DJ3, you're putting out there something that HILT really could be a rallying point around. So let's just put a little flag there and maybe come back to it, because I think that that's been repeated in lots of circles and conversations. Thank you, Healthpoint. Let's move on to a very different environment. We'll go to long-term care. And so Angie, if you can tell us a little bit more about what have you learned, what is still really important, and what's even more important from a nursing staff perspective in a long-term care setting at Aegis.
Absolutely. Thanks, Lindsay. And thanks, DJ3 and Heather. I think we have a lot of similarities in the needs. So you'll probably already start to hear themes. But in a long-term care environment, and specifically, for us, we focus on assisted living and memory care. And what our biggest challenge, I think, obviously through COVID, was perception in a lot of ways. We really struggled with the media. And everybody thinks all retirement is a nursing home, and all of the negative connotations that came out of that was and continues to be, I think, a challenge, specifically when we are attracting talent, retaining talent, and in the nursing space, it brought to the forefront just the absolute criticality of the nurses that we have on staff, and how important it is for them not just to manage the care of our residents, but also to manage families and expectations of families, which was a struggle, especially when families weren't allowed to come in. They needed to know, what was happening. It created all kinds of, in some cases, pretty uncomfortable situations in the senior care realm. So as far as staffing needs, we've seen a severe drop in the talent pool and the available talent out there. And because of the increased need that we realized we needed to have, we need to have that nursing expertise, that infection, prevention and control expertise on site all the time. So we actually increased our nursing needs while experiencing a decrease in the available talent in the market. So it definitely has been and continues to be a struggle for us on the staffing end. And as far as, just preparing and moving forward, we have done a similar, I think, exercise that you were talking about, DJ3, around how are we creating pathways for those nurses? So once they come in the door, what are the things that we can provide to help them realize that they're growing their career? Our environment's very different from even primary care, and definitely from acute care. And so we, how do we attract those nurses that truly care about the aging population and cognitive decline and caring for that, and helping people live their best lives in their final years? And that is, that's a specific niche that's hard to find, and definitely isn't something that's taught in the schools. And so helping nurses understand that this is another path for you in your career, if this is something you want to explore, definitely focused on the overall long-term well-being of aging adults, and understanding everything from dementia to physical decline, et cetera, and helping them live their best lives. So, I think that kind of covers a couple of different things, around the skill sets that are needed. That family relationships has been just, I can't even tell you how critical that has been through this. And so that's a communication and empathy, a way of communicating to families in distress who can't see their loved ones, who might have COVID, that has really bubbled up as a skill, that we've realized we've had to help our, nurses develop, that they might not have had naturally. Dealing with the patients themselves is one thing, or the residents themselves is one thing, but then dealing with the dynamics of family in that type of a stressful environment is a whole other thing. And I think the other thing too, we realize we have to be ready, right? I mean, I think if anything, we all learned this is something nobody expected. And, please don't let something like this happen again that we're not ready for, but it could very well happen. There could be something else. And so always being ready and mindful and being safe and creating that safe environment at all times. And it's our nursing staff and our nursing leaders in our communities that lead that effort and make sure that that's the case. And, they're doing an amazing job, but we need more of them. And so that's really where and why I wanted to participate in this is just, I think that we are an area that sometimes gets forgotten out there in the nursing space, both on the nursing side and otherwise, just simply because, we're not that shiny penny of, whatever it might be if folks want acute care or even primary care, disease control, things like that, or not disease control, but disease management. We're a little bit of a different animal, and we need people too. We need strong nurses too. So.
That's great, Angie. Thank you so much. I think, you reiterated much of what Heather shared, but I think also put a different twist on this, an angle, right? Just the criticality of nurses in the long-term care setting. Shelley from Klein-Galland, also from the long-term care setting, reiterating, this great need, right? The need has gone up, the supply and the pool has gone down, right? And so that's sort of this big overarching elephant in the room, but also the students and the nurses who really do have a particular place in their heart and want to go into care for the elderly is a particularly important one. You also mentioned resilience, right? And resilience and readiness, and how do you embed that into nurses coming in. Lots of conversation in the chat box too. I hope you guys are monitoring it. Sentinel Network has been mentioned, I think at least 4 times. This was sent out by Liesl, of course, to the entire HILT network earlier this week. So another great opportunity to make sure your nursing needs are being specified specifically. This goes to the Washington State Legislature and also is just terrific statistics for everybody to use going forward. And then also lots of conversations around the different types of nurses that are needed. It's not just BSN, it's ADN and community health nurses as well. So thank you so much. We are going to now transition to a big hospital setting and go to your sister, Jennifer Graves at Kaiser. And Jennifer, if you could answer the same questions, but obviously from an incredibly different setting. What needs, skills, knowledge, changes are you seeing in your nursing staff at Kaiser?
Yeah, thanks for the invitation to be here. And I have to laugh a little bit because I've worked with Heather for a long time, and I've worked with Angie, and I've worked with Doreen, and I've worked with Vicki, and most of the people on the call over my 3 decades here in the Seattle area. So it's really nice to see folks. And Heather, I had to laugh because if you could see my notes right now, they are like almost exactly the same thing. So I haven't seen you on the soccer field recently, but I'm still in your head there. Yeah, as was announced earlier, I work kind of with 2 hats at Kaiser Permanente. I work in the quality and safety world as the vice president and also as the chief nursing officer. And so I think my perspective on the questions kind of spans both of those things, actually, as I think of the position that I desire that nursing take as far as leading healthcare and making sure that we are the profession that guides us into the safest and highest quality and best experience for members of our community. Definitely the pandemic has increased the nursing needs in our system. I think we realized very early on that we needed to figure out how to ramp up our numbers in our workforce just to cover things like who's going to do COVID testing and how many sites are we going to do that across the state, and who do we partner with to do that most effectively, whether that's public health or other organizations or even private industry. So that whole, I think, testing and now vaccination has really increased the nursing needs, and we've had to be very creative on bringing back people who were recently retired, perhaps, that might want to work with us, or how do we bring in and hire nursing students into nurse tech positions to get them familiar with our organization early on and provide them opportunities to look at COVID and our pandemic response with a different lens. So definitely our needs have increased. I think Heather referred to people retiring. I know when you look at the statistics, I think both internal to our organizations in Washington, but across the country, it's anticipated that nearly a quarter of people or so are anticipated to want to actually leave the nursing profession by year end. And that's a really concerning number. So that's not a KP specific number, but it is something we need to be prepared for and make sure that we are thinking ahead about that now. And if these are folks that we would like to keep, how do we keep people and provide flexibility in our systems that may not always be really flexible systems, right? To help keep people that we want to have caring for our patients. And then I also, two people have spoken about resiliency now, and I think our needs will continue to be high as we know that many of our nursing staff have not had time off, or what I would call sufficient time off during the last 14 months. And I think anticipating how do we best care for our caregivers is going to be need. So continue to be a high need. So definitely the nursing needs have increased at Kaiser Permanente. Nothing particularly new about the changes related to nursing as we prepare for post-COVID environment. I 100% agree with the comments made about population health and looking at our communities differently, instead of as individuals, but as collective families and small communities. I think this is particularly, I know we're talking a little bit about COVID here, but I also think about the pandemic that we are dealing with as far as racism and social justice needs. And I think one of the biggest changes that we're going to have to lead forward with, and it is hard work. We're undoing 400 years of oppression and things that are ugly. And I think, our organizations are going to really need to prepare for a post-COVID environment, but hopefully a more just environment as we move forward. And that is going to take a different set of skills than some people have in our institutions currently. And how do we partner and help bring equity and equitable care to all, I think is something that I am very, very passionate about. So I would throw in equity there in addition to the population health and case management comments. Another few things that have been alluded to that I would say too, we talked about the ambulatory environment, the long-term care environment, and memory care environment. I think the virtual care environment is going to continue to play a very strong role for care delivery. We're finding that while we had to pivot quickly and necessarily to provide most of our care virtually because people could not come in or didn't want to come in even. I looked at a study this morning that said, about a third of members of our communities did not seek care during the pandemic and are still hesitant and have had worsening of chronic health conditions and other things. And I'm thinking, wow. So how we're used to in healthcare, a lot of people presenting to us. And I think another skill we need to think about is how do we reach people who maybe have been unreachable perhaps. And so I think that requires a very different skill set of come to us, bring the volume, we can take care of you. And now it's, my gosh, how do we care for people in the corners and of our neighborhoods and in different ways, and provide care outside of our usual four walls using both technology and in-person skills, whether that is mobile, whether that is providing care in partnership with barbershops to check blood pressures, whether it is working with our churches and communities of faith. I think nursing is going to look a lot different in how we deliver care, and it's not going to be in the four walls, if you will. And so I would say the last couple questions, skill set. Name of the game, I think, is flexibility. And how do we help nursing? How do we help build people who are coming into that pipeline of nursing and for our current workforce that embrace flexibility and are willing to live on that kind of edge of fear sometimes? I know as a nurse, when I floated to different areas in my clinical practice, I always had like slight nausea. I don't know if that makes sense, because it was always scary to float someplace else, right? And Vicki knows, we worked together on some night shifts, but it's like, okay, you never want to be really, really comfortable, but we need to get people really comfortable with being uncomfortable, right? About how do you flex to maybe work in a different place this week than you had next week, and making sure that we're providing the organizational resources to help our nursing staff be successful as they are in that space of flexibility. Critical thinking, I think, in a virtual world and in the new world is also, can't stress that enough. We know that pivoting care from in-person to virtual is not the same, and it requires a very different attention span and a very different focus as far as how do you get down certain question paths and thinking to get to the right outcome for patients. So, and then we already talked about, providing care with a lens of equity and inclusion and diversity. And that is a new skill set for very many people, to know that not everybody fits the same algorithm, and how do we think, again, flexibly for our patients. And then finally, effects outcomes our system is experiencing due to COVID. I'd say there's been a lot of positives and silver linings. I would say, public-private partnerships, how we look at nursing differently, how do we work with our labor partners to make sure that if we have staff that desire working in flexible relationships or even flexible locations, that we can make that happen. So I think that flexibility is an effect, an outcome that has been welcomed, because it's forcing us in a little bit different direction. And I would say, I'll probably end there because I'm just at my time, but lots to say, but I appreciate my colleagues that have spoken before me, because they articulated many of the things that I would like to say too. So thank you.
Well, Jennifer, thank you so much, because I think that not only did you reiterate some of the common themes and really important themes, but I think you also refined some of them. And so, the additional comments about just how important the community health settings and sort of that integrated setting and getting nurses into those settings is going to be, the stats that you're presenting around leavers, nurses that are going to leave the systems right when they might be needed most. So not only the population health and case management skills and knowledge, but the deliberate ability by nursing staff to understand the deep-rooted equity and justice issues and how that translates to care settings. And then one that I wrote down too was the fact that during COVID, people haven't been going to their doctor. So the increase and the severity potentially of chronic and co-occurring diseases. So it's a scary thought, right? That influx is going to happen very fast and hit pretty hard. Jennifer, you're on mute. Yep, there you go.
Two mutes here. One other thing that I think is worth mentioning again, that I think Heather brought up, is the ability of nurses to be able to understand data and make changes in their practice near real time. And, we've often relied in nursing on, it's changed. If you look at old literature, it says, it takes an average of 17 years from something, our R&D practice in healthcare is long, right? You study something in research and then it's maybe fully implemented in 17 years. We have to be able to use today's data that we have today to make changes. And whether that's with single patients or with small communities of patients or larger communities, we've learned that through COVID that, oh my gosh, today we're seeing this variant in this community. What are we going to do today? Today we know that Johnson & Johnson, we've had 6 women who have been affected by this vaccine. What are we going to do today? Not next year, not next week, not in 17 years. And so comfort with data and analytics and making decisions on that data is really, I think, going to be a different skill set for many nurses.
It's an incredible point. And with that, because I know that Doreen, we'd like you to speak next from the perspective of public health of King County and Seattle. And obviously, that ability to understand population health metrics, but then also the real-time data coming in that requires agility and flexibility by a nurse and critical thinking to make a good decision. So excellent transition, potentially, I'd say, to you, Doreen.
Essentially, as I was listening to my colleagues, I just have to put exclamation points and underlining the points that they made, because those skills and the challenges and the resiliency, everything really is the same in public health. Our core work is different on a day-to-day basis pre-COVID, but I think we're all in the same boat right now. Our nursing staff has probably doubled since COVID. We had about 350 nurses. We have 700 nurses now. So and a lot of them aren't with us full time, but they're probably people from your organizations that are volunteering with us at our call centers, at our high volume vaccination sites. That's just partnering with other nurses in the community has been such a gift for us. Changes to nursing in our system. I think the $64,000 question is what are things going to look like tomorrow? What's the post-COVID world? I think my biggest appreciation has been for, and I think the biggest learning, the students that we've been partnering with in our call centers and in our high volume vaccination sites. They're coming to us with solid skills in understanding the social determinants of health and the impact it plays on our community. They know the impacts of racism on the health of our community. And I think Jennifer said our nurses that we're hiring our public health nurses get all of that. But new nurses that we're hiring in who have been nurses for a while, they're not coming with that skill set. So sometimes the students that we're hiring and that we're working with that are volunteering and doing their clinical rotations are teaching others next to them. And that's really been really wonderful. I feel so comfortable in seeing the amazing nursing students that are coming out and how caring they are. And it's really refreshing from a public health perspective. And I'm assuming that my colleagues are also experiencing the same thing. There's no other effects or outcomes that we're experiencing that haven't been mentioned. Obviously, the nursing shortage, we are not able to compete with agencies, wages, the COVID, what are they calling them? Like COVID pay that people are getting in other places. We don't have that luxury. So we're relying a lot on the generosity of our Public Health Reserve Corps and retired staff, and not just nurses, I mean, everybody. And when you look at vaccination centers, that can be done by a lot of skill sets. So we're working with medical assistants, EMTs, nurses, LPNs, RNs, public health nurses, nurse practitioners, physicians, pharmacists, anybody that can give a shot, dentists, anybody that can give a shot, they're coming to the forefront. So it's been I am so thankful that I live in King County. And when I just see what's going on in the rest of the rest of the country, we're very, very fortunate to be here. CDC came and visited us yesterday at our ShoWare Center, and they were singing our praises. And we're known throughout the country for the work that we've done here. So I want to thank all of you, because we couldn't have done it without you guys. When I think of Jennifer and KP and working side by side at the assessment center, recovery centers, I mean, these are things we've never done before. I've had nurses that work in mother baby and do parenting and lactation specialty, and they're answering phones in a PIC center. They're working in isolation and quarantine with adults. Those aren't skills that they had going into this a year ago, so ramping up and training and getting enough things in place so people can receive safe care with a very short turnaround. So it's just, I mean, I think working with students and working more closely with our staff side by side, like I am now, I mean, my regular days are at the ShoWare Center. So that's been so much fun. That's been the true gift of all of this, is really get to be a nurse again, not necessarily just sitting behind a desk. And, the desk now is my office at home. We've moved out of our office spaces not even just for this COVID, we're moved out. So it's, how do we lead in a world where you're not working next to somebody? I think that's a different way for me to think about how to engage with staff when you're not necessarily with them. And it's different. So I don't really have anything else to say, because my colleagues have covered everything, and I would just be repeating all the main points that they had given.
Well, I appreciate it so much, Doreen, because I think reiterating and the exclamation point comment from the beginning that everything that has been mentioned are the key trends and themes. We're going to make a quick pivot here, and just because of time, we feel, I hope you agree, that this is such a rich conversation so far. So we're going to go to our education speakers for reactions. We will probably not break out into breakouts this time, but maybe just get the chat box really going, and even speak up and interact as we go forward, if that's okay. Thumbs up if that works. Okay, great. So Doreen, again, thank you. And before we shift to our education partners, I'll just say, Doreen, I think so much of what you said really tugs on the emotional heartstrings, right? It's real. It's just how important the criticality, as you said, Angie, of nurses and nurses in the field and in the community doing nursing things, right? I just think it's incredible to even hear you, Doreen, say, wow, what an experience to be a nurse again, but also to hear that King County is hitting it out of the park, right? So a question came up in the chat box that any of our kickoff speakers, if you could try to address. I think it's a very good one. We hear lots about how the demand for nurses is up, 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 up. We're scared about the exodus that's going to happen of nurses at the end of the year. But what about 10 years from now? Do you think, can you speak to, is this going to affect some permanent level changes, or at least permanent in a 10-year outlook timeframe? Any comments on that might help from an education standpoint understand what all this means? Open to any of you to speak up from healthcare organizations.
Jennifer, I think you should take it because of being on the WCN board. That's my vote.
That would be Doreen. Probably all of us could take this. Yeah, I think, I would say even, I think our entire careers, most of us would say we've always heard about the nursing shortage, right? From the 90s and the early 2000s, 2010, 2020, the Institute of Medicine still shows in most of our stuff that there is going to be a gap. I actually think this last year is a gift to us because we've been planning that gap around around what we know about giving care in a fairly traditional way. And I think if we look about giving nursing care and nurses being leaders and leading teams to give care, I actually feel a little bit more confident than I have about our future than maybe I did before, because again, speaking to that, the flexibility piece, the renewed partnerships with our academic partners on building building curricula that are, about ambulatory care and long-term care and virtual care. I think that I'm more confident that even though we have people leaving the profession, maybe because of fatigue, that I think a lot of those people are salvageable and with the right flexibility on the part of our organizations. But I believe we'll still be, the desired profession. We're still the most trusted profession, and I don't see people. Doreen was talking about the nursing schools. I don't see people in the nursing programs right now shying away from the profession. I see them totally leaning in, and as she said, sometimes leading us to be better people and better caregivers. And so I feel hopeful that with new models of care, we're going to continue to face challenges, but I don't think the gap's going to continue to explode like I might have maybe worried about 2 to 5 years ago. Just my personal perspective, not a KP perspective necessarily, but I feel hopeful.
That's great, Jennifer. I appreciate that comment too, that we've been talking nursing shortages for decades, but we've always tried to solve it from a traditional perspective. And in many ways, this last year has pushed you into some new ideas of how that might be solved. Other quick comments before we shift to our educators?
Yeah,
So
I was just,
go ahead.
go ahead.
I was just
Jennifer.
merely going to say, we've got to think about how we better connect in the long-term career development.
Mhm.
We do a great job of the clinical, and we focus on the clinical, but then what happens is we get into the dynamic, and then there's those interpersonal communication skills. There's those team building skills, being effective. So how do we help them build those strengths, and where are the best places for us to situate that learning? Is some of it beginning to plant the early portion as they're coming through their developmental programs, but then as they move into the organization, we are augmenting that with programs that we've built that continue to support that learning as they move forward. Because as you think about this, not only do we need to provide that next level of by the bed, by the patient side caregivers, but we also have to provide those administrative roles and those management roles and those other leaders who are going to be helping supporting nursing as they're going through. So how do we create that next round of Jennifers and Heathers, and how do we do that in partnership with our learning partners?
Yeah, I would just say one thing too, and I'm hoping, I think Ann Hirsch is on the line and going to speak, so I'll maybe tee her up to address that thing too. But that is where I think interprofessional education and not training nurses as an individual profession, but in the same room as the medical staff, as the pharmacists, as the social workers, teaching team steps. That's just a methodology that we use a lot in the quality and safety world, but it really hinges on, if you look at high reliability organizations, whether it's nuclear power, whether it's the airlines, whether it's healthcare, has still some things to be desired. A lot of that hinges on how do we communicate most effectively. And I think that interprofessional education and using models like team steps and not having siloed hierarchical education any longer is going to be a ticket to doing some of that before people even come to us as new graduates.
So I'm going to use that to transition, because that is perfect, because guess who's next? Ann Hirsch is next, in fact. So we're going to switch over. This is incredibly rich discussion. We want to now really hear more from the post-secondary institution side. And so on our list of speakers, Ann Hirsch, Associate Dean of School of Nursing from University of Washington, is going to kick us off, followed by Mary Burrows, Dean of Health Occupations and Nursing from Shoreline Community College. Julie Benson joining us, Associate Dean of Nursing from Tacoma Community College, as well as Steve Simpkins, Program Director of Nursing and CNA programs at Highline College. So a great lineup and mix of our 4-year as well as our 2-year institutions. if we can go to the questions, James, you'll notice healthcare organizations, you got off easy. Look at all these questions we're asking the educators to respond to. But they've also been told that really just pick the ones that feel most relevant and that you have the most depth to respond to. But lots of questions, and probably even more, right, that have now come up out of our healthcare speakers. So Anne, we will kick it to you now from University of Washington to respond to some of these questions. Again, keep it to 5 or so minutes, and we'll keep the conversation going.
All right, thank you, Lindsay. And 5 minutes, I'll do my best. So, you know, the pandemic has really put a highlight on nursing, on the nursing profession, to the point where we had a huge number, a huge increase in applications to the nursing program. People are interested, very interested in what nurses are doing. It's portrayed all over the media. And not only for acute care, because they see the intensive care nurse being the hero, but also in population health. So I want to report to my colleagues who will be very, very pleased. Our population health DNP program applications tripled this year. So we have not, the trend line has been here, and all of a sudden we're tripled. So we're going to have a very robust class, and we'll be coming to you all for those clinical learning opportunities. But our BSN applications were 700. We accept 80. We would love to be able to accept more than that. So that's one of my themes today. What's keeping us from being able to take more? It's nursing faculty and it's clinical placements. So if we could embrace the idea, we need more BSN prepared nurses. Where could we put the resources so that we have what we need to do that, and work with our clinical partners to enhance those clinical placements? Our ABSN program, and these are individuals who already have a baccalaureate degree, just not in nursing, we're 400, and we can take 64 of those. Again, same limiting factors. So when COVID happened, there were some changes in the way we provided clinical learning. We were not able to go some places, although the people in the room that I'm thinking of were all very welcoming of our students. So thank you, Doreen. Thank you, Jennifer. Thank you, Heather. And we found ways for our students to continue that clinical learning in person as much as possible, but also we did a great deal with clinical decision-making using VSIMs. So I'm thinking that the students coming out will be strong in those clinical decision-making skills, but they will not have the competence, because even though they had a wonderful learning experience, and most of them will say that, it was different than what they expected. So they think, but I didn't work many shifts in the hospital. I didn't have one of the classes that didn't have a senior practicum that was typical. We needed to have faculty on site with them. So they weren't in that independent learning role. So they see it as different. They may need additional mentoring because of that lack of competence. Some may not. So another area, let's see, messaging and referral to students who did not get accepted. We continue to work with our applicants. We give them feedback on their application. We're part of the reason that we had such an increase is we did not require clinical experience prior to application this year. We had to let that go. Nobody could do a shadow experience, or we didn't want to encourage them to move into a healthcare system that was overwhelmed and maybe at that time did not have PPE. So maybe that will go back down, but as I said, we'll continue to work with them and refer them to other schools if that's appropriate. But we're very blessed with the robust applicant pool. The demographics of our nursing school admissions, we are really trying to get a handle on the racial and ethnic demographics and not just, but underserved populations for all of our applicants. We're going to have a dashboard that's going to be accessible from all. I was pleased to see that we do have a disproportion of applicants who are accepted in the right direction. Students from diverse backgrounds have a slightly higher level chance of being admitted than those who do not come from diverse backgrounds. And part of that is our anti-racism efforts. We are launching, it's a major step at the University of Washington, creating a Center for Anti-Racism in Nursing. We hope to lead the community, not just the community, but the nation on this, because we acknowledge and we know that there's an urgent need to not just talking about the systemic racism and all of the diversity, equity, and inclusion issues, to doing something about it. So the dashboard is going to be one of the first steps, but we also want to educate our students to deliver optimal healthcare and begin to address and redress the healthcare disparities that Jennifer talked so eloquently about. So part of it will be research, part of it will be education, but we do want to establish that center. So anti-racism, ambulatory care, Jennifer called that out, social determinants of health. Thank you, Doreen, for calling that out as well. We are finding, and this is serendipitous, that we are addressing that in our curriculum, but many of our students, most, if not all, come with a fairly good knowledge of social determinants of health and how it affects healthcare. So it's happening younger and younger, which it should. And we're hoping to build on that. Interprofessional education, we're building a new educational health sciences education building that is really designed to provide an environment that has flexible spaces, modern technologies that will foster interaction, collaboration, and creativity for students and all those in the healthcare community. So we're excited about that. Sometimes you need the right structure, but the content will be there as well. Let's see, go back to the questions. Those are some of the changes in the curriculum. Understand the need for flexibility. As somebody said, who knows what's going to happen tomorrow? Wouldn't that be nice if we did? We do need to look at clinical settings that are a little out of the box that we've generally been in. Nursing hasn't been a profession that has fully embraced innovation. We're starting to do that. We worked with Doreen and Jennifer to have our students at the ACRC at the call center. We're looking at some of the downtown emergency services center and the permanent supportive housing as very meaningful clinical opportunities, working with underserved populations. So we're pushing the envelope a little bit in terms of how we supervise students in those clinical settings and trying to embrace innovation, because we cannot be totally dependent on our healthcare partners, especially in acute care, providing all of the learning opportunities that our students need. Has your faculty capacity changed pre and post COVID? Well, it did, because the university mandated that if our students were going to be in a potentially COVID positive setting, that faculty had to be on site. And that is not generally the way that we provide graduate education or for senior practicum students. So we'll probably ease back a little bit, but even so, we have to be open to having a bit more faculty supervision. And the legislation to provide resources to pay nursing faculty has not had an effect on our ability because we were not eligible for that. And so the four-year institutions, and in particular the two research universities, have actually been hurt by that because the competition for higher salaries that comes now from the community colleges who benefited from that. And I think probably the private institutions have also been impacted by that.
Great, thank you, Anne.
Mhm.
A lot of information packed in there, and I think a lot of responses and reactions built into what we also heard from our healthcare organizations. I definitely encourage everyone to keep scrolling through the chat too, because I feel like there's some repeated themes in here to certainly pay attention to. Angie, I love this point that you made about senior living as a great way for applicants not accepted to start their healthcare career and their experience. It does make me think too, to DJ3's points about how do we actually use, you know, HILT as a forum even to create a pipeline, a much more connected pipeline and deliberate way to plug students in at the right places. I feel like that also relates very much to the repeated theme of what about ADNs? What about ADNs, which well, I think we'll hear more about as well. Steve, you had raised that. So, Anne, thank you very much. You did indeed address all of the questions, which we did not fully expect, but appreciate
Can
it.
I add one thing?
Very quickly,
Just
yes.
fine.
I want to make sure we get to the others, but yes.
I totally understand. I do want to say that in terms of recruiting and preparing students for a career in healthcare, the nurse camps, and the younger we can make that connection with young people, the better off we are. And that's where our nurse camp is very, very well attended. We'd like to expand that. So
Excellent.
a strategy.
Thank you for that, Anne. And it jives really well with what the HILT Talent Pipeline Committee is up to right now in partnership with Tacoma Pierce County of really getting the message out to students in high school specifically, and specifically students of color, about nursing as well as other healthcare occupations. So thank you for raising that. Let's jump forward, and again, I'd encourage you to ask questions and answer questions too in the chat box. If you see a question that you have an answer for, please type it in. I know everybody's capable of multitasking, right? And so Mary Burrows, we want to hear from you from Shoreline Community College, Dean of Health Occupations and Nursing. Thank you, Mary, for joining us again. And again, don't feel like you have to address all of them. If you want to address ones in more depth, it really is up to you and from Shoreline's perspective.
Great, thank you. It's always tough to follow Anne. She's so eloquent in the way that she speaks. So I'll be, yeah. So applications definitely increased. We typically have 170 applications per quarter. We admit 3 times a year. We have about 170 per quarter. And for the fall cohort, we have 220. So it's definitely increasing. We also did some changes in our application process, which just happened to coincide with this fall group as well. And those were efforts to increase credit for being diverse and having experience in at-risk communities and with, excuse me, diverse populations. So I'm not sure if that made an impact on it as well, but definitely increased. We still struggle with what to do with those students that don't get in. It's a large amount. I see about 10% of them who don't get in will come to me and ask for advice on how to get in. And we talk about the strategies of the different programs and how they all are admitting with different criteria. So if they're not strong for one program, they may be nice and strong for another one. So trying to help them strategize that. Demographics are definitely changing. We're seeing a much larger African-American or African descent population, which I'm pleased to see. We continue to work on that. We're really focused on increasing that diversity of our student body. One of the things that we're doing is we are starting in winter quarter, we're starting an LPN to RN cohort of 8 students that will be admitted each quarter. So we know that diversity decreases as the educational level of healthcare workers goes up. So we're hoping that that will also help bring some diversity in having those students. We're very excited for that change. Curriculum changes. This past year has caused so many curricular changes due to what's happening in society. We have integrated COVID content into all of our lectures. So regardless of what we're talking about, we're talking about COVID, infection control, impacts, and the latest research with that. Our students have been driving us for diversity and equity. And I love it because they're truly driving and are creating some great changes in both the way that presentations are done in the classroom, as well as activities that the students and faculty are contributing to on efforts related to DEI. Our curriculum is also based on CUSIN, so it's teamwork and collaboration, safety, quality, patient-centered care, evidence-based practice, clinical reasoning, and professionalism. And so those are concepts that I heard a lot were necessary concepts, and it was affirming to me that we're on the right track with those things. The social determinants of health into the curriculum, again, we're really focusing on that. We've changed, we have a communications class and a health promotions class where we've really increased that in those courses, but also in the other courses as well. Graduates are much more interested in community health and population health, and that's from an ADN program. We definitely, they are not as hospital-based in their interests. We certainly have those students, but we see a lot more students that are interested in alternative nursing roles. Faculty capacity. When I read this the first time, I thought about how tired our tenured faculty are. They are exhausted. It is hard work to work with nursing students. There's a lot of issues that have come up during this last year that they need more support. And it's typically our full-time faculty that's assisting with that. So they're tired. They're really tired. On the flip side, our part-time faculty have been taking on more load because I think they prefer to be in the clinical setting with students as opposed to the clinical setting working. So that's been interesting. The legislation has helped dramatically with faculty. We were really fortunate to get that funding, and we're grateful that it appears that it will be in the final budget for the next biennium. But it really has made a difference in the ability to hire quality faculty and to keep them.
That's great, Mary, really. And I appreciate each of the pieces that you hit. I saw a lot of smiles and nods around that more of your graduates are interested in the community health side. And so obviously a repeated theme from our healthcare organizations, and that this legislation had an impact and has made a difference. You know, I think a lot of nods and agreement as well to the fact that full-time faculty are burnt out, but adjunct faculty potentially wanting more. And so I think those two things are interlinked, potentially an area too for HILT to throw advocacy weight behind to even up that, ante based on that legislation and potentially the outcomes. Mm-hmm. Thank you so much. We're going to go ahead and jump forward. We're definitely, we definitely packed these panels, didn't we? But I appreciate the chat interactivity. Julie had to leave. We're going to go to Highline. Steve, you've had some incredible comments, I think, and some reactions to what has been said already. And so Steve Simpkins, Program Director of Nursing and CNA Programs at Highline College, let's jump to you again. Don't feel like you have to answer all of these, and also feel free to react to some of the common themes and trends that you've heard so far. Steve?
Sure, yeah. I don't know that I have a whole lot to say that hasn't already been said by Mary and Anne. Again, both of you are eloquent in what you put forth. But I do have some additions to it, I think. So as far as applications to our program, I'm in the same boat as Mary. We have had consistent numbers of applicants to our program. And again, I want to emphasize the fact that we really haven't had room for growth despite having those high numbers of applicants. And a lot of it, I think Vicki was saying in the comment boxes, or someone was, that there just isn't space clinically for us to get our students into a clinical setting for clinical hours. So it's been a real challenge in that sense to try and grow. But that is in our future. That is something that we really hope to do. We generally have similar numbers as Mary's, about 170 applicants, and we take 28 students each quarter. We enroll quarterly. So we are turning a lot away, and we have some students who have been waiting up to 6 and 7 quarters to try and get into my program. And that's where I think that I've really worked hard to start working with students earlier in their pathway, and encouraging them to not just focus on one program, not just focus on our program. Even if they're doing their prerequisites at our school, they can be applying to other programs. They can continue on with a transfer degree, so they can start applying to BSN schools as well. So they have different ways that they can continue on with their education, because we just find that people will stop trying after a while if they aren't getting in. And that's the last thing we want to see, I think. Demographics, we have a very high percentage of students of colors and immigrants in our program. We stay right around 70% students of color and immigrants as far as our student body. And that's reflected in our nursing program at Highline. And I don't see that changing much. One thing that I really love about what we're doing at our college right now is they are focusing on disaggregating data as far as it pertains to students of color. And so one of the things that we've been talking about is it doesn't matter how many students of color you have in your program, it's whether or not that they're being successful in your program and getting through your program. And so that's really encouraging to me, because that's something that I think Highline has fallen back on for so long, is that we're one of the most diverse campuses on, in the state. But that doesn't mean anything if they're not getting through your program. And I think that we have had a lot of success with that. One area that I'm seeing some struggle with is our English language learners, and really struggling with being able to complete the program. They take the TEAS test, and without disaggregating a TEAS test, they can get into your program with a reading skill score of about 18. And so that we've had some trouble with that area. And so that's one area that we're beginning to focus on, and really try and find ways to help those students get through our program. And I think they're a real asset to what we want to try and do in healthcare, right? Because we want people that speak multiple languages and reflect what they're seeing in our healthcare environment. And I think that that's something that we would like to see changing in our curriculum, is how we can implement that into our teaching, and the different ways that we can be a part of healthcare with our students. We already put in a lot of our social determinants of health into our curriculum. That's kind of woven in and out of our curriculum. But I kind of brought that up earlier in the chat box about the community health nursing is something that we would love to see more of in nursing, but that's also a BSN focused part of the curriculum. And that impacts our students who are getting ADNs. A lot of my students are like working 2 and 3 jobs just to pay for the school that they're doing now. They have families at home, sometimes families of up to 12 people in the same household. And the idea for them of going on and getting a bachelor's degree is incredibly daunting. And we're seeing Multicare just came out with a decree that all of their nurses have to be BSN trained within 3 years of hire. Other organizations are doing that. That's a nationwide movement and studies show that there's better outcomes when they're BSN trained. But I really feel like we're building barriers to our students and nurses of color by making mandates like this. And without looking at ways that we're going to help them achieve their goals and the goals that we make requirements. So if we are going to be having rules like that, then we need to come up with ideas about how we're going to help them fund their education. You know, our organization's going to help them pay for their schooling. How are we going to get more students into the community health nursing roles if they don't have that BSN training? So just some thoughts that kind of I was going through my head when I saw some of the other presentations. Like Mary's group, we have a lot of students who are interested in community health nursing and home health and long-term care. But there are a lot that still want to go into acute care, and we need to make sure that we give them the bridges and the pathways to get where to accomplish their goals. How has faculty capacity changed with COVID? I've actually been really impressed. When we first started this, some of my older faculty were scared and they were ready to walk out. But they have buckled down. They've learned new technology. They've just gone above and beyond, and I've just been so impressed with them. And you know that I've lost one faculty member over this entire COVID thing, and she was close to retirement anyway, and slipped on some ice and broke her ankle in 3 places, and decided it was time to hang it up. So it wasn't COVID related, really. As far as bringing new faculty in, though, the salary increases have dramatically impacted the ability of us to hire and retain faculty. This last hiring session, I had 8 applicants, and I've never had more than 1 or 2 applicants at a time. And it was always before I had to take whatever nurse came my way, whatever faculty came my way. I didn't have a choice of picking out somebody that actually had the skill set of the class I wanted them to teach in. So it's impacted us tremendously. I mean, literally, we had faculty who were making less than the ADN nurses they were putting out, and those nurses were making the first year in their career. They were making more money than what our nursing faculty was making at community colleges. So I can't emphasize enough how important it was for us to get that originally and for them to be renewing it for this next biennium. I think that's it.
Thank you, Steve. That's terrific. That's it. You reiterated, everything that's been said and added some nuances. It's a lot, right? And I feel like this particular topic, we knew it would be a lot, and that we're so grateful both to the healthcare organizations and our educators who spoke to these questions very specifically. Also, of course, many of you already know, and I know, Brenda, you are on, the Washington Center for Nursing is also working on this very topic, right? The post-COVID impact on nursing education and changes in education, as well as the pipeline of nurses that represent communities of color. So I'm making a plug, of course, for that, because we are very eager to see those reports and findings when they come out in a few months, we hope. So just in the time that we have, there's so much in the chat. There's a lot that has been raised. Are there any sort of big takeaways, or what really has stood out or been illuminated via this conversation so far? And that is open to anyone, really. So just in the minutes we have, what stands out and what's been illuminated? Steve, do you want to make a?
Yeah, can I just want to, and this, I thought about this earlier when our healthcare providers were presenting, is like, I would love to have representatives from your agencies come to my campus and talk to students or Zoom with them about opportunities to come work with them. We have like all the major acute care centers come out to us and come to talk to our students. I think that would, any way that we can get students into your, because if they don't know about you, then we have no way of, yeah. Gotcha, Angie.
That's great, Steve. And
Yeah.
I feel like HILT would be a great organizing structure to really enforce, get to some of your nursing students in the post-secondary institutions. Other takeaways and what's been illuminated here for you?
I think the main thing is one of the things, it's a theme that you probably didn't think about, is many of us know each other and have been in the same circles, circling over and over and over again. And let's stop circling and start getting out there and making the change. And that's been probably the hardest part. And I'm glad WCN's on board, and I see some other like the allied health folks are on board as well. But we really need to start leveraging the work that has been done historically by WCN and C News, of course, and then leaders like Jennifer out of Northwest One. But we need legislators to understand what we need to help for access. We need to really address funding. We keep hearing about funding, and then it fizzles away every year at the legislature. We need to really leverage and support our public health colleagues. The reason we're in this boat, in good ways and bad ways, is public health was decimated. And what's public health made of? Nurses. And so, we need to leverage this sad opportunity called a pandemic to really start working forward. That's what I see, because about half the people on this call I know personally, and I've known them for a long time. Even Dan, I remember, right? So we keep talking. So can we, really leverage this work group and these other leadership groups to change the focus around circling and moving ourselves forward, and getting more, like I said, more funding, and getting the legislative branch involved in different leadership groups.
That's great, Heather. Thank you. Dan?
So I want to thanks Heather for the call out, and I want to call out DJ for your earlier comment around kind of the need to think developmentally about how we train nurses and really anyone across the healthcare continuum, health workforce continuum. So we can do a lot around communication and soft skills and interprofessional practice, and understanding healthcare cultures. But I'm thinking, we can embed some of that information into early education experiences, but we need to kind of recreate opportunities for that ongoing learning throughout their career, and kind of actually really, DJ, you're giving me some like high fives or something like that. Come on. Because I'm constantly advocating for example, more opportunities for our nursing programs to do team-based interprofessional practice and education. But do they have the time? Is the nursing commission like really driving it home in terms of what they need to put into their curriculum? Maybe, maybe not. And so where do we put that? Anyways, I'm just going to pose that question.
That's great. Thank you, Dan. So we are at time here, and so I'm going to throw out just a few things, and then we'll wrap up. But I'm hoping I heard some of these three things right, and also really heard what you said, Heather, which DJ3 I think is music to your ears. That we must have a bias toward action here, right? And so if we are to have a bias toward action, let's do something. Steve Simpkins, I think you offered something that is really a doable thing, right? Which is rally the troops, which are the 70+ healthcare organizations that are part of the HILT network, to get into nursing schools and programs to talk directly to students about the settings, the needs, the knowledge, the skills, the changes, the expectations, right? So there's a thing, there's one thing, right? Another thing that I heard is the advocacy muscle, right? And HILT needs to test this a heck of a lot more, right? HILT has just scraped the surface of advocacy muscle. But if we're hearing that that legislation had a significant impact on getting nursing faculty engaged at higher levels, and we know we need more students to be able to be accepted in, it is a money thing, isn't it? So it's money for faculty. It's also money for students who need that support, especially the students of color. And so then there's this third piece, which is a little bit bigger, but I think it's the, how do we really map out the nursing pipeline for our region, right? Keep this regional, and HILT is sort of expanding into sort of partnering more with our Pierce County partners and our Snohomish County partners. How do we map out the pipeline, the nursing pipeline, and what was the term that you used? I can't remember, but identifying the sites where the training needs to happen along the whole pipeline, right? So not only going down into middle and high schools to build the pipeline, but nursing students as well as the graduates and nurses that have been nurses for a long time, right? But need engagement as well. And so is there some project, has that been done already? Or is this a project that a HILT network could try to nudge and take on, of mapping out that pipeline and identifying those points and places of training and additional training? I don't know. DJ3, I'm looking at you. You can't tell, but I'm looking at you wondering, is there something here, do you think, in that third piece?
Oh, it's absolutely. It's the right learning in the right time, in the right amount, in the right modalities. So it's not coming with a big, huge program per se. It's aligning ourselves so that, hey, we're creating awareness in elementary and junior high, where we're starting to get people thinking about healthcare careers. As they become more middle school, high schoolers, we're now starting to come in with maybe some application, some learning there that's beginning to introduce them to healthcare type things. As they move into secondary schools where they're getting that mastery and learning the skill and the craft, we're starting to coach, we're starting to mentor, we're starting to connect them with people that can help them start thinking about what that pathway looks like. And then we're augmenting that once they come into our organizations with not only clinical proficiency, but also the other related skills that will help them become well-rounded leaders, nurses, members of the team.
Great. That's great.
You know, I would just add to DJ's comment, the reason we've struggled with that over the years, and Jennifer and Vicki and I and others can remember this. We've tried it with WCN, we've tried it through CNews, we've tried it through various organizations at the elementary school and above, is two things. One is having the bandwidth to get out there to share and engage with the younger age groups. Two, is also the funding. It takes money to do that, whether it's producing a video or a brochure or whatever. And then I'd say the third thing is our school nurse organization should be at this table a little bit as well, because that's a group that does great work that has very little bandwidth, that actually does a lot of, I'll say, unintentional recruitment of young kids into nursing because they do such great work. But I think that's the biggest challenge is being intentional, having the funding and having the organizational bandwidth, whoever's leading this, to keep it going. Because we've done this multiple times, but never been able to sustain it.
Thanks, Heather. Okay, well, we want to get you out of here. We've gone a few minutes over, but here's what we fully expect, at least as the HILT convening team, James and myself and Liesl representing the convening team today, but also I guarantee that the captains, including Denise Banuelos from Kaiser and DJ3 from Healthpoint and Angie from Aegis, who joined us today, will be taking this back up as well of what came out of this and what does HILT need to do. For all of you, you know that you can and should, in fact, we ask you to please send follow-up emails with, yes, I'm willing to try to figure this out. You know, what is the right learning at the right time and the right modality pipeline for nursing that we need to map out and figure out? And what would a project like that look like? In addition to getting out to students and testing the advocacy muscle, which were the other two actions named. So if there are other pieces, please do follow up. Before you hop off, if you click those three little buttons at the bottom of the chat box, you can copy the chat box and all of the conversation in there for yourself. It'll save right to your desktop. And there's a lot in there, so I'm encouraging you to do that. James, I think that's it. Am I right? When is our next information exchange?
Absolutely. Our next information exchanges, we've got a few big events coming up. We have a HILT Spring Quarterly meeting, May 20th. That is from 9 a.m. to 11. We would love for all of you to come and join us. And then our HILT Summer Education Information Exchange. This is the spring. Summer's coming right up. It's going to be here before we know it. And we know that that's on July 21st. That's from 3 to 4:30. So please, 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 do reach out. Invitations will be coming out. Mark it on your calendar. Save the spot so that you are here to engage with all of your fellow colleagues and partners, and so that we can definitely get this group into action.
Thanks, James. Thank you, everyone. Thanks, captains.
Thank you.
Thank you, speakers. Have a great afternoon, everyone.
Thank you.
Bye.
Thank you. Bye, everybody.
Bye-bye.